I invite Dr. Thomas Churian, immediate past president of KSOS and senior consultant in retina services and deputy medical superintendent at LF Angamali. I welcome you, sir, for your talk on posterior segment manifestations in trauma and its management.
Thank you very much, Sindhu and Deepa, for the invite. I'll quickly go through the posterior segment manifestations in trauma and its management. As you all know, there is a closed globe injury and an open globe injury, and both these can cause a lot of posterior segment manifestations. In closed globe injury, we have a choroidal rupture. This doesn't require any active management. However, if the choroidal rupture passes right through the fovea, there is an impact on the final visual acuity. Sometimes a choroidal rupture can cause a choroidal neovascular membrane, which has to be treated with anti-VEGF. Otherwise, it's best left untreated. Commercial retinae, it can be caused by blunt trauma. We see commercial retinae as an area of pale retina with a glistening appearance. Again, the management is conservative. Most of the time, it heals by itself. Traumatic macular holes. Due to blunt trauma, you can have macular holes. The visual acuity could be anywhere between 20/30 to 20/400. The difference from the idiopathic macular holes in traumatic macular holes is the possibility of a spontaneous closure. Though it is mentioned in literature as traumatic macular holes can close up to maybe 6 to 9 months, we usually wait for about 2 to 3 months at the most before surgical intervention. And the management, the surgical management is same as that of an idiopathic macular hole, where you go for a pars plana vitrectomy and ILM peel and a fluid gas exchange with a prone position. Retinal dialysis is another posterior segment manifestation of blunt trauma, where there is disinsertion of the retina at the ora serrata. Supranasal is the commonest location, and there could be an associated retinal detachment. If there is no associated retinal detachment, you find only a disinsertion, you can manage with a prophylactic laser. If there is a retinal detachment, the option is to go for a scleral buckling. Giant retinal tears can happen after trauma, especially in young individuals. Trauma accounts for about 16% of giant retinal tears. The management of giant retinal tears is again pars plana vitrectomy, unfolding of the GRT with a perfluorocarbon liquid, endolaser to the edges of the giant retinal tear, and a perfluorocarbon silicone oil exchange. I didn't give you the description of a giant retinal tear. Any retinal tear occupying more than 3 clock hours or 1/4 of the retina is by definition a giant retinal tear. You can see retinal breaks in trauma, where you can treat it with prophylactic laser photocoagulation. Retinal detachments, you can have it immediately after trauma or after a couple of days or weeks following the trauma. The presenting visual acuity depends on whether the macula is involved or not. If there is only a subclinical retinal detachment localized to 1 clock hour or so, you can have a prophylactic laser photocoagulation around that. Beyond that, you go for a scleral buckling, and sometimes, depending on how much of is the involvement and where is the location of the tear, you can go for a pars plana vitrectomy or endolaser or silicone oil or gas tamponade. Vitreous hemorrhages can happen in both the closed globe injuries and open globe injuries. Patient presents with symptoms of floaters. Visual loss depends on the extent of the vitreous hemorrhage. You have to do a thorough fundus examination to look for retinal breaks. If there is no fundus view, go for an ultrasound B scan to rule out retinal detachment, tears, and choroidal detachment or dislocated lens. If there is a fundus view, and if you are almost sure that there are no breaks, then you can go for an observation and conservative management. If you are not sure whether you have a break or not, call the patient back maybe at 2 weeks or 3 weeks. Again, look for it till the vitreous hemorrhage clears and you are sure that you are not missing a break. In case where there is no fundus view and B scan shows retinal detachment, vitreoretinal surgery is the mode of choice. Posterior dislocated lens, yes, the only way out is vitreoretinal surgery followed by an iris claw lens or a scleral fixated lens. Optic nerve avulsion is the most disheartening of the injuries which you see. The optic nerve gets avulsed from the lamina cribrosa. Visual acuity is PL or no PL, and there's nothing much you could do about it. It heals by fibroglial proliferation, but the prognosis is extremely bad. Vitreous base avulsion, sometimes you see a bucket handle in the periphery. There's an avulsed vitreous base from the retina and pars plana due to differences in the elasticity. Again, just like a vitreous hemorrhage, go for a thorough peripheral examination. Here, once you have a vitreous base avulsion, the tear could follow. So one examination is not sufficient. Do the examination repeatedly, either till the tear develops or till your PVD extends and completes. Close follow-up is recommended. Chorioretinitis clopiteria is by definition a full thickness rupture of the retina and choroid caused by blunt trauma, where areas of white areas of bare sclera can be seen adjacent to the choroidal rupture. In these cases, do a CT to rule out a foreign body. The prognosis depends on the other ocular injuries associated with this, and if there is an intraocular foreign body or retinal detachment, go for the surgical intervention. Open globe injury, the most dreaded problem is intraocular foreign body. Here, detailed history is the most important. Repeatedly ask the patient whether you have seen the object which hit your eye, which has fallen off. If the patient clearly says that I have seen something which hit the eye and I have got it, that means you are almost safe, almost sure that there is no intraocular foreign body. But many times you get like, I was hammering, something hit my eye, nothing was there, that most likely there is an intraocular foreign body. And proper documentation is critical. Patient could be symptomatic, patient could be asymptomatic. There could be a lot of intraocular foreign bodies, there could be high velocity metallic foreign bodies, there could be non-metallic foreign bodies, glass pieces, and the difference is metallic foreign bodies are usually high velocity foreign bodies which goes all the way into the posterior segment, while the glass and wooden foreign bodies usually stay to the anterior segment or in the anterior vitreous face. A careful slit lamp examination is needed to look for a wound of entry. There could be iris holes, there could be lens injuries. Do a thorough fundus examination, look for a foreign body, and if you are not seeing it, go for a CT, which is the most foolproof thing. Ultrasound, yes, but then foreign bodies are better picked up on a CT. And if you are strongly suspecting a non-metallic foreign body, then the better option could be an ultrasound or an MRI scan, but not for a metallic foreign body. There is a high risk of endophthalmitis in intraocular foreign bodies, so intervene early. Prophylactic antibiotics are needed if there is a contaminated wound. Now we have post-traumatic endophthalmitis. It's usually caused when the wound repair is delayed beyond 24 hours. The contaminated wound, retained intraocular foreign body, and also you have to look whether it is an inside-out injury or an outside-in injury. When there is a trauma, when there is a blunt trauma causing a rise in intraocular pressure and the globe ruptures, it is an inside-out injury which is very unlikely to go in for an endophthalmitis. But when there is a sharp object cutting the eye, the sclera goes inside with an open globe injury, that is an outside-in injury which is more likely to cause a post-traumatic endophthalmitis. Again, B-scan, CT orbit to rule out intraocular foreign body, and surgical intervention as and when necessary. I'll go through a surgical video, but I won't go through the entire video. This was a boy who got an injury in a chemistry lab of the school while he was doing an experiment. He had a corneoscleral tear which was repaired, total hyphema, and ultrasound showed a vitreous hemorrhage with a retinal detachment. And here in this one, I first aspirated the hyphema. Yeah. When you do the vitrectomy and clear, you find the large retinal tear close to the posterior pole. Now you clear all the debris there. Then there was lens matter, which was also cleared. And after you clear the lens matter, retina was attached. You do a laser and inject oil. I'm sorry, I thought this video was edited for 1 minute, but just 15 minutes back I realized that it was edited for 3 minutes. That's why I'm not showing the entire video. Sympathetic ophthalmitis, a granulomatous uveitis. It can be caused in the contralateral eye. It can occur any time between 5 days to many years after the trauma. Sympathetic ophthalmia has to be managed with systemic steroids and immunomodulators, and it requires close follow-up. Thank you very much.